Minister, let's talk about the national health insurance idea. Do you accept that private healthcare companies should make profit? And if so, how much?
In terms of the Medical Schemes Act, the medical aids themselves must not make profit. They are not allowed. They are mutual funds. There shouldn't be any profit there. They accumulate money in order to pay for your services when you are sick, and that's what they are there for. So all the money they collect must be for payment of that offices. Of course, there will be administrative fees and all that.
Yes.
Yeah, but then there are providers who are mostly private hospitals and private doctors. Yes, they've got to make a profit. They've got to make a profit, but it must not be exorbitant.
So how do you set the bar for those controls? Because it seems what the NHI is going to do is in part say, okay, well, there will be a lot of money going through those channels. We'll put the money in government hands. That seems to be one of the fundamental things you're trying to do. You're also making changes to the Medical Schemes Act.
We're putting which money in government hands?
So money that I pay in my medical aid, that money will go into the national health insurance, won't it?
Yes. We are making a pool from which we'll purchase services for all citizens.
And government will do that?
Well, the scheme is being set up by government, but it does not necessarily mean that the people who are going to manage it are government necessarily. If you read the bill about the committees that are being formed will control what.
But government appoints all those committees.
Yeah, yes, they do. Exactly in the same way as is happening in NHS in the UK.
Yes.
Which has been happening for the past 70 years.
I want to understand this, Minister. You painted a picture in launching the NHI bill of what sounds like a very predatory private sector, getting money from the state, getting subsidies, getting tax rebates and so on. But you put up a stat which I thought was interesting. 26% of people in metro areas have medical aid, but 37% get their healthcare from the private sector, which suggests to me that rather than people on medical aid going to the public sector, it's actually the other way around, that people who don't have medical aid are going to the private sector because they're not getting the services they need from the public sector. That's what that number says to me.
Yeah. So what's wrong with that?
No, nothing at all.
Because under NHI, we are actually encouraging that.
Yes.
That you can't have one set of people going to receive services in two areas.
Yes.
People who have got medical aids like myself and you, when you are sick, you can go to the private sector. When your money gets finished, you still have an option of going to the public sector. So you have got two options where you get your healthcare services. But those who are poor, who are not on medical aid, they've got only one option. Even when it becomes very necessary, they can't exercise any other option. Let me give you an example. You find that the hospitals around Pretoria, all the public hospitals, their ICUs are full. And it's often like that, where the ICU is full. And there's a baby who comes in who needs ICU. And you phone around, all the hospital is full. But there's a private hospital where the ICU is empty. What makes it difficult to put the baby there and say, here we're saturated, some must flow over into the private healthcare system? We are trying to create such a system that all facilities must be used by everybody. Even the poor must have access to the private healthcare facilities. And that can only happen if you have got a pooling of funds, a body that is very strong in pooling funds and controlling things. Basically, that's what we're saying. And for people in public healthcare to go and look for treatment in private healthcare is something that has been happening for quite a long time. Only that because of exorbitant cost now, it's becoming more and more difficult or more and more impossible. But it should not be allowed to go in that direction, actually.
I want to refer to something in the amendments that you're making to the medical schemes legislation, where brokers are now going to be abolished. Those services are going to be stripped out of the system. And you said that would be taken over by the Council for Medical Schemes. The Council for Medical Schemes at present, certainly according to their last annual report, have 100 employees. There are 7,000 registered health broker entities, and they presumably employ many, many more people than just that 7,000. How have you ascertained that the Council for Medical Schemes with 100 people can pick up a load that's currently being served by a massive number of people and a huge number of entities?
Well, people have to get concerned because they need to understand. But what you are saying is not what I said.
Mm-hmm.
I never said the work that is being done by brokers is going to be taken by Council of Medical Schemes.
Yes.
I never said so. I need to correct that.
Okay.
I said when we check the situation as it is now, or maybe let's explain first what brokers do. What does a broker do? In the insurance business, a broker recruits people to join a particular insurance company. And then once you join, you pay them premiums for those services. And they keep on looking into the market for a better policy option for you,
right,
in insurance terms, right? That is in the insurance world. In health, now we also have brokers, which, by the way, increased exponentially only in 1998. The system never used to have so many brokers. What do brokers do? We found that what they do is medical schemes have now put up options. You know, some medical schemes have got 16 options. The government one, GEMS, has got 5 options. And we believe those options are unfair because they classify people according to the amount of money they earn and give them treatment according to their earnings. That's not how healthcare systems should run. You don't treat a person's high blood pressure differently because he's a DG and the other one is a PE, is a PA. Then you give them different treatment. There's no medical textbook in the world that says that. So firstly, the options themselves are wrong. And if you need brokers to put people into options, then we are claiming that we don't need brokers. And then I said, most of the work which is supposedly done by brokers is also being done by the Council of Medical Aid Schemes. Many people, as I said, about 2/3 of people on medical aid do not even know that they've got a broker. Do you know that? I don't know that I've got a broker. I don't know. I've never met any human being who's my broker. But I'm paying 90 Rand towards that brokerage fee every month. If you are on a medical aid, you are paying brokers' fees. And I said,
so why not cap the fees rather than abolish the relationship?
Because it's a service we don't need. You seem to be proposing that now people are going to lose jobs and all that. And I'll repeat, the aim of the healthcare system is not to provide jobs for people. It's to provide healthcare to the citizens. But it so happens that you'll need people who will provide that healthcare.
Minister, I would assume that to run the system, you're going to need very effective, fast, and systems of high integrity at the back end, electronic systems. And I want to get a sense of your faith in your department to set those systems up, if indeed they're going to set them up. I'm looking at what the Auditor General said about the e-health strategy, which is trying to wire up all the components of the health system around available information. It says little progress has been made with the implementation of the strategy in the provinces due to budget constraints, IT critical vacancies, and a lack of prioritizing the implementation of the initiatives. In addition, minimal progress has been made regarding the development of information and communication technology infrastructure. And it goes on to make some other points. It would suggest that your department doesn't have a great track record in getting these systems up and running, and making sure they work. How is that going to affect NHI?
Well, we have started preparing for this for a long time, John. We discovered that by 2010, since 2004, the 9 health departments have spent 4.5 billion Rand on health information system, but none exist that talk to each other.
Yes.
South Africa doesn't have a health information system, which, you know, a unique patient identifier, which can trace a patient from one health facility to the other. For instance, if you are in Eastern Cape, on ARVs, you leave, you come to Gauteng, we won't be able to trace you. We won't know whether you have died or you have opted out of the system. Now, we have been looking for that system, and because we realized that going into the private sector to look for a system, money has already disappeared. I mean, has already gone without having that type of system. We then put a moratorium on such systems in 2010. And together with Home Affairs, CSIR, Department of Science and Technology, we came up with a system which is called Unique Patient Identifier. As I'm speaking now, we have already put it up in 2,900 clinics out of 3,500. This year, we are putting it up in 22 hospitals. That includes the 10 central hospitals and the tertiary hospitals in the country. 22 of them are going to have this system together with a new filing system. And by the way, we have already registered 23 million people on this system as I'm speaking. And as it grows, because it's been done in phases.
Yes.
One of the phases is that we're going to have paperless filing system. That's what we are moving to. But it has to be done in steps. The reason that it has been so slow, or you might not even know about it, is that when you look at the terrain, we've got a team of 25 people who for the past 3 years have been full-time on this. When they arrive in some of the clinics, they have to start first by looking at broadband, which is not there in many areas, connectivity and all that.
Is that system ready for the national health insurance system, which will massively load it with new layers of complexity?
We have not yet finished the system. I've just told you. So it's work in progress. And the fact that we don't see results yet doesn't mean we are not heading there. We are certainly heading there. Because without such a system, you can't run NHI. There's no question about it. We need to be able to trace patients from one system to the other. At the present moment, by the way, before that system, we still have people who go to a clinic, test for HIV, and they found that they are positive. They go to the next, do the same test, hoping it will be negative. They can go to 5 different facilities without us knowing and repeating the same test.
Yes.
That's the system we are running, and it worries us. Or even more ominously, we know of people who collect ARVs from one clinic to the other, and they can do so without us knowing. That system we are implementing is going to make us immediately know that, no, but you have been in that clinic 12 o'clock.
Minister, I'm going to finish off by giving you 3 wishes. Here's your first wish. What's your wish for healthcare in places like Pokwane, a rural village in Limpopo where you grew up?
Well, I want improvement. I want good quality, efficient healthcare system. That's my dream.
What's your wish for doctors and nurses?
Well, I wish we are able to produce and hire as many as we can, enough, because human resources is one of the cornerstones of the healthcare system, the health workforce. We need to do that, but not only doctors and nurses. We are also planning that community health workers, because of primary health care, must become a permanent workforce of the country with career pathing.
Last wish, what's your wish for yourself?
Well, the wish for myself is to get strength, to be able to implement all the things that we are dreaming about, especially in the National Health Insurance Bill. There's a lot of work. It needs a lot of energy, and my wish is to get that energy to be able to do that work.
Minister Aaron Motsoaledi, many thanks for giving us your time on Under the Skin.
Thank you very much.